obesity casts a long shadow over our well-being. But what if there's a beacon of hope in this shadow? What if bariatric surgery, with its potentials to shed excess weight, also offers relief from these burdensome comorbidities? Bariatric surgery, although we say it's not magic, but it's magical in so many different ways to see the resolution for other illnesses that comes with morbid obesity.
I mean, it has been clearly shown in many studies that bariatric surgery actually increases the lifespan of people, right? On the other hand, it has also been shown that obesity decreases the lifespan of people, right? The higher the body mass index, the lower the chance for a person to achieve their full life expectancy. So
diabetes, hypertension, sleep apnea, hypercholesterol, joint pain, depression, liver disease, so many really important illnesses. It usually comes with either morbid obesity makes it more complex and complicated, or it's happening because there's morbid obesity. I'm going to say this. We are the only bariatric program who has daily case conferences, and all patients are being discussed on a daily basis. And I'm there, you are there.
Yep.
Our nutritionists, our nurses facilitate the practice. And if you can kind of give us the background on these issues first, and then we can start from there.
Absolutely. Many people may question the idea of going to the doctor to lose weight, right? To say, why do you need to see a doctor to lose the weight? Well, because first of all, it's very difficult to lose weight, particularly when people reach certain levels of weight, but also more importantly, because once we get to a certain weight, we also develop very serious illnesses that we're calling comorbidities, right? These are illnesses that come with obesity. In fact, Kemal, a better term for this would be to call them complications of obesity, because sometimes when you say comorbidity, it suggests a coincidental presence of two entities that may have the same background, maybe the same risk factors, but they may not be causally related.
Right.
But the key issue here is that when we talk about these illnesses, obesity actually is directly causing those illnesses. So they should be called complications of obesity as opposed to comorbidities of obesity. And what happens essentially is when the accumulation of fat in our body exceeds a certain limit, it becomes an inflammatory process that instigates really the arisal of all these illnesses that you mentioned, metabolic conditions like type 2 diabetes, cardiovascular problems like high blood pressure, heart disease, and of course, we talk about sleep apnea, and you mentioned many problems with joints as well, and liver disease, many problems. And of course, our traditional approach as doctors has been to treat each one of these illnesses as if they were all independent and separate, right? Well, now we know better. We know that if we are able to take care of the central problem, which is obesity, then we will have resolution of these problems as well. And that's essentially what it happens after bariatric surgeries. The person comes in with a very high body mass index or a lot of weight. They have bariatric surgery. They lose weight. They lose 60 pounds, 70 pounds, 100 pounds, 120 pounds or more. And as the weight goes away, so do these illnesses that have been caused by obesity, essentially. And we obviously focus on this greatly as doctors. Of course, we're happy to see patients lose the weight, having a more comfortable life, more self-confidence, liking themselves, shopping for clothing that they like, right? All these are good outcomes and good things. But where we focus as doctors, Kemal, is what happened to the high blood pressure? What happened to the type 2 diabetes? What happened to the sleep apnea? And with bariatric surgery, we see these illnesses either going away completely or become much more improved from the way they were before the surgery. As the weight goes away, as the person becomes lighter and lighter, as there is less and less excess fat in the body becomes insulin sensitive. right?
Right.
Which means that the blood sugar doesn't rise quite as much, and there is no need for medication. So this mechanism can occur over 6 months after the surgery, although the improvement is seen really within the first few weeks. Very often, our patients will call us and saying, when do I start my diabetes medication right now that I have had surgery? And the first question we ask them is, have you been checking your blood sugar? And they will say yes. And we ask them, what is your blood sugar level? They say, well, it's fine. Then we say, don't take the medication. And on other situation, we may say, well, you still need some of your medication, but you don't need as much. And as time passes, they need less and less medication. But generally, the timeline would be anywhere between the 3rd and 6th months after surgery.
That's great.
Yeah.
So when after the resolution, would they come back? What's the chances of these comorbidities coming back, and why? If so, why it would happen?
Well, essentially, the main problem was the excess accumulation of fat, right? We did the surgery and we got rid of it. But as we say very often in our program here, bariatric surgery is a very powerful tool, but it's not a magic wand, right? Which means that it is important for the person to incorporate key lifestyle changes that we want them to uphold for the rest of their life.
Right.
If they fall off from this type of commitment, it is possible for them to start regaining weight. And guess what? As the weight comes back, the weight starts causing the same complications that it caused even before the surgery. So yes, these conditions can come back, even to the levels, to the pre-surgery levels, if the person is not careful. Now, this is not very common because bariatric surgery is a very efficient way for losing weight, and the vast majority of people are actually able to keep their weight off, or the majority of their weight off. So we don't see really this condition is coming back, but they can, just as the person is able to regain weight if the person is not careful long term.
So now the way that these complications, the patients who are fearful with these complications, but also they actually can benefit the bariatric surgery the most. How do we handle those types of patients? What's the way of counseling them? And since you see these patients in the office, when they are in the exam room, how do you handle those?
I think it's, first of all, it's very important for the patients to be educated about the long-term effects of obesity, right? Obesity is not just a question of inconvenience or appearance. It is a disease that causes many other diseases, right? So, and that trajectory is clear, right? We've seen it play time and time over. And patients will also tell you that, when their weight was a certain level, they didn't have high blood pressure. When their weight was a certain level, their blood sugar was normal. When they start gaining weight, those conditions come. Now, we have to educate them. We have to make them understand that these conditions are not harmless. Not only they are dangerous conditions that will have an impact on their quality of life, but they can shorten their life expectancy as well, right? With high blood pressure, you have potential for stroke, you have potential for kidney failure, you have potential for heart attacks, right? And with type 2 diabetes, similar problems as well. We have to make them understand that these dangers, no matter how much medications we throw into them, are going to be there. And we make them understand that bariatric surgery can go a long way to help them get rid of these risks and of these conditions.
That's one of them, is the depression. And
absolutely.
Being able to go back to what we're able to do in terms of socializing, in terms of one-on-one relations with others. So this has a huge impact.
It does.
On the individual in terms of managing the depression that most likely caused by morbid obesity. So, but this is why we need people, our patients, to have full commitment. And when I was helping my new assistant for the projects with the BMI, we are going through some of these, and 100 pounds, Dr. Guys, 100 pounds in 6 months.
Absolutely.
That's a miracle.
It is.
Right?
It is. Absolutely.
And on top of that, this procedure is not something that someone needs to stay in the hospital for a month or for a week, so they go home same day.
Yes.
So what else can we do?
Yeah.
Right?
Absolutely. I think it's all again about education and for people to understand also. I think we are making some headways, not only in making sure that the public understands, but obviously even within our own health profession, we have to get people to understand that obesity is a central problem that is driving so many of these illnesses. And just telling people to lose weight is just not enough. It's not enough because it doesn't work. People will come after a lifetime of struggle with on and on, gaining and losing, gaining and losing, gaining and losing. And then they find themselves really at very high levels, right? And they feel defeated. And as you said, by that time, they will have developed so many other medical conditions and they will be on different medications. And those medications, frankly, they are almost patching up rather than helping them, right? With this information at hand, I think we are able to inform people, we are able to educate people. Of course, we're not saying that just bariatric surgery is the answer. Far from that. We're saying that a comprehensive approach where bariatric surgery is part of that approach is critically important. Of course, we are going to help people. We're going to help the providers also select the patients that are going to be best served with bariatric surgery because we have the data, we have the experience to support it, right? But we have to make sure that bariatric surgery is part of the options that are presented to patients because it's a very, very effective treatment.
Right. When you were going through that, and I know, I think we covered the resolutions. I think that since there's a playlist on the channel related to the resolutions, so there should be at least 8 of them. So people can get more information from that, from those playlists. But I couldn't help but wonder when you were actually explaining this issue with, think about this way. So you have the surgery and pretty much the surgery doesn't bring you any additional risk. Not only that, it actually destroys those problems that we already have, right? But when I have a patient on a weight loss medication, every medication comes with side effects.
Of course.
So the surgery's side effect is the resolution of comorbidities. But when in the uncontrolled setting, I want to be careful there because we still support the weight loss drugs. But if it's in the uncontrolled setting, meaning no one is measuring them, following up with them, and no nutritionist on board, and the patient is on this medication for 2 years with no outcome, that's dangerous. Would you agree?
Oh, absolutely, absolutely. Just like the proliferation of online dispensaries that are really telling people, encouraging people to get those medication with remote supervision. It's not really appropriate. You need a programmatic approach where changes in lifestyle, education about nutrition, close follow-up are really part of it, right? And we shouldn't be, and it's not necessarily medication versus surgery versus other things. I think these are all options that a program that is experienced in weight management should be able to offer patients, right? And unless it's done in that setting, obviously you are setting up people for failure. And as you correctly said, some patients could be on this medication for quite some time without proper follow-up. And not only, obviously, you worry about potential side effects that could be harmful to patients and not being detected in time, but also the fact that these patients are just getting the potential for side effects without getting the benefits of this medication is because appropriate supervision is not being provided, essentially.
Right. And also the cost.
Of course.
So $1,600 to $2,500 a month. If you see a result, go for it. I mean, this is, again, it works for some, it doesn't work for some. So you can try, and then we do that as well in our
Yes, of course.
offices.
Of course.
So we also have a bariatrician in the program
Yep.
under the United Medical ACO. We have actually two bariatricians, one in Seaford, one in Wilmington. And if medication works, that's great. But the thing, in many of these cases, we are expecting this miracle, magical, you know, I'm going to take this pill and then I don't have to do anything. I'm going to eat everything the way I, like right now is what time is it? Like 3:30, 3:40. I didn't eat anything since last night. So I'm pushing the 19th hour.
Good for you.
So it doesn't happen easily. So, and this is Monday through Friday. So
Right.
like just Fridays, maybe a little bit longer, but it's still 17, 18 hours.
Yeah.
This week, because of the cold, we couldn't walk. So I have to be a little bit more careful because I don't have enough steps. So this is, nothing is magical in this case. Nothing is magical.
Absolutely.
So that needs to be understood by everyone. And this is also true for the surgery, but the surgery doesn't come with side effects. So someone who's 57 BMI shouldn't be on medication only to see that if they're going to lose 15, 20 pounds. That's not how it works. Now, we have another study that we are working on with our own patients in the ACO to see how the progress is for them, how much weight loss we are able to see. And then we are going to share those in the future
Great.
episodes. Now, one of the really exciting updates from our side is next week we'll have Karen Riley, who is one of our patients.
Absolutely.
Who's going to join me in here in the studio. So we did record something with her, and there were some technical issues with the connections. So then we asked her if she would be willing to come and do the session here, and then she agreed to do it. So
that's wonderful.
And she's someone who has seen a lot of positive outcome from her own journey, and we are going to share that with everyone next week. And then we have other sessions coming up. Now, morbid obesity is a chronic illness that impacts a lot of things in our body and how we are managing day-to-day activities, to psychological issues, to other chronic problems. So the solution is very simple. There are different solutions, but if at a morbid obesity level, the surgery is going to be the best options. Doing that with a program that's multidisciplinary like ours. And anyone actually has a different, if I'm not actually accurate with what I say. It's about a complex web of health challenges it brings. From diabetes and hypertension to sleep apnea and joint pain, obesity casts a long shadow over our well-being. But what if there's a beacon of hope in this shadow? What if bariatric surgery, with its potentials to shed excess weight, also offers relief from these burdensome comorbidities? Today, we are going to dive into a fascinating topic of resolution of the comorbidities with bariatric surgery, and we will untangle science behind bariatric surgery and its impact on various comorbidities. There are so many other illnesses we call comorbidity. You don't like when I do comorbidity, when I call it comorbidities, but let's call them other illnesses alongside with morbid obesity. And one of the, I guess, very effective part of this powerful tool, bariatric surgery, is the impact, the changes that we see in other illnesses that person may be having. And as an expert, you are going to tell us what you see, what you have seen with your patients, and what are the other help of bariatric surgery. So that's what we would like to discuss.
Absolutely, absolutely. Kemal, if you look at the top causes of mortality in our country, in the United States, you will see at the top cardiovascular disease, which includes heart disease, high blood pressure, stroke. You will see metabolic diseases, which include things like type 2 diabetes. You will see cancers, right? And surprise, surprise, obesity is closely related to the development of all these major causes of disease as well as death in our country, right? So it is no surprise then that people who have morbid obesity also tend to have a shorter lifespan, because with obesity we have a concurrent disease, including high blood pressure, as you mentioned in your introduction, type 2 diabetes, and other illnesses, including cancers, right? So interestingly, the existence of these diseases alongside obesity is not coincidental. It's actually causative, right? Obesity actually, as a disease, causes these other illnesses as well.
Mm-hmm.
I mean, we can look into the scientific reasons for that, but without that, we can just do observational studies, right? You have about 3 out of 4 patients who have high blood pressure are obese patients, right? In about 90% of cases, type 2 diabetes is caused by obesity, right? So there is such a close correlation between the existence of these illnesses and obesity that it is no surprise that when we focus on obesity as the main culprit and get rid of it, Kemal, we see resolution or improvements in these other illnesses as well. So before really the popularization of bariatric surgery the way it is now, especially among healthcare workers, right? Among the general population, there is still not enough knowledge of bariatric surgery. And that's why I'm so thankful for you having this session has come out, because we want to get this information out. But among healthcare workers, the understanding of this miracle cure that can take care of many illnesses in one go has taken hold now, right? So 15, 20, 25 years ago, you would go to see a doctor, right? And they would measure your blood pressure and say, oh, you have high blood pressure, right? Here is medication for it. And then they send you for blood work and they find out that your blood sugar is too high. Oh, you have type 2 diabetes. Here is medication, right? Oh, you are very tired during the day. Oh, let's check for sleep apnea. You have sleep apnea. Here is a machine to take care of it, right? Let's do screening. Oh, we've done mammogram, you have breast cancer. We've done colonoscopy, you have colon cancer. And yet, with all that, the discussion about obesity, which is right front and center, was not there in those days, right? Now things are changing. Healthcare doctors really are understanding that the central problem is obesity. So when they see a patient who has morbid obesity, rightly, they focus on that. And then they explain that the high blood pressure, the type 2 diabetes, the sleep apnea, the risk for those cancers is actually related to it. So addressing obesity will also address all these illnesses. So it is very, very important now to understand that when patients have high blood pressure, they are also at risk for many other illnesses, Kemal. They are at risk of heart disease. They are at risk for stroke. They are at risk for kidney disease. And kidney failure and dialysis are terrible problems that are extremely difficult to treat. With bariatric surgery, actually the same mechanisms that lead to weight loss actually influence the metabolism of the person in a beneficial way. So there is almost like an independent improvement of things like type 2 diabetes just because of the procedures. So much so that, Kemal, that right now there are places in the world, not yet in the United States, places in the world where bariatric surgery, particularly in the form of gastric bypass, is being offered as a first-line treatment for type 2 diabetes, independent of the weight of the people, right? So you can have people with a body mass index of 27, 28 with type 2 diabetes. They are being offered gastric bypass as a definitive treatment. And why is this happening? This is happening because for many people, type 2 diabetes is a never going away illness. It's an illness that they will take to their grave, right? It's chronic problem, right? And even when the best control with the best medications, the risk of amputations, the risk of blindness, the risk of kidney failure, the risk of heart disease or stroke remains with that person when they have type 2 diabetes. That's why many doctors are advocating the use of metabolic surgery. That's how they call bariatric surgery, even in instances where the weight issue is not that much great, right? So when we say if you have obesity, if you have morbid obesity and type 2 diabetes, bariatric surgery should be something you need to look into. Bariatric surgery should be something your doctors should be asking you to consider, is because it's based on that, Kemal, because we are able not only to liberate that person from the burden of obesity, but also these very, very dangerous illnesses like type 2 diabetes. Some medications that are critical for them to continue taking. This could be medications for high blood pressure, for instance. They could be medications for anxiety or other mental health issues. But there may also be medications that they have to stop taking on the day of surgery. All those are obviously very individual situations that will have to be thoroughly discussed with their surgeon before their surgery. So if they have medications that they have been instructed to take, they should take them with a sip of water. On top of these medications that patients may have, there are actually some medications that the bariatric center will instruct patients to take before they come to the bariatric center on that morning.
Now, are there certain medications that we want them to avoid, though?
Of course, of course. For instance, if a patient has type 2 diabetes and they take, let's say, metformin, that would be a medication we would not want them to take, because if they do, then their blood sugar could be driven too far down at the time of anesthesia, and the anesthesiologist obviously would not like that.
Mm-hmm.
But as I said, these are individual situations, and it is important that at their surgical clearance visit that they discuss with their surgeon which medication is to hold off and which medication is they should be taking. Our medical record will have a list of their medications, so we know what medication they're on, and we will tell them, but it's important for them to really have that clarified in their head, okay? Now, as I said, there are certain medication the bariatric center actually will or may ask the patients to take. For instance, we like our patients to take Tylenol extra strength before they come to our surgery center. Now, people may find this puzzling to why would I want to take Tylenol? Well, one of the things we do in our surgery center really is to prepare the patients for a comfortable recovery. Not necessarily painless recovery, but a recovery where pain is really very well controlled. And one of the things we do is actually provide pain medication ahead of the surgery itself in order to really prepare them to have less discomfort. And it has been proven if you give patients Tylenol before the surgery, actually you are able to mitigate the amount of discomfort that they will have after the surgery. So if they are instructed to do that, obviously they need to take the Tylenol extra strength at home, perhaps about an hour or so before they come to the surgery center, again, with a sip of water. Mm-hmm. All right? Tylenol extra strength. It's very important they clarify this as well, because sometimes people think Tylenol pain medication is similar to Motrin, it's similar to ibuprofen. These are very different medications that have very different effects. So it's important for them to be very clear in my mind about the instructions that they are given. So they come to the surgery center, as you said, usually it's about 2 hours prior to their allotted time for surgery, and they will be registered at our in our lobby, and then they will be going to, with the nurses to the preparation area. Well, they will be changing into a gown, and that preparation will start really with a number of questions asked by the nurse to them, but also by other people. And they may find that these questions are repetitive, right? That there will be a number of people that will come and ask them same questions. When was the last time you had anything to eat or drink, for instance, or what medications have you taken? And patients may think this is redundant, right? But it's really part of our safety process. And redundancy is very important in medicine, right? You have to have different layers of safety so that different people will come from different angles to ask the same questions to confirm that the facts stated are really the fact, right? This is important for safety reasons. Very often patients will find it strange that their surgeon will ask them, "Oh, what surgery are you having today?" Well, the surgeon is asking that because not because the surgeon does not know, but because the surgeon wants to confirm as part of the safety process from the mouth of the patient that they are understanding what surgery they are having. And this is part of the informed consent process as well, right? Patients need to understand clearly what procedure they're having, what are the indications for that procedure, what are the potential risks, complications, and expected outcome, the commitment that is needed for that expected outcome. All these are part of the informed consent process that will be starting earlier on in their first counter, but it will be repeated through the process until they are also in the preparation area where this conversation will be rehashed again and will be rehashed by different people. So I don't want patients to be surprised by that. It is a very important part of our safety process.
Patient in the OR is about like 60 to 85 minutes averagely in the OR.
Yeah, absolutely, absolutely. So that would be right. Yeah. So for instance, sometimes if it's a revisional procedure, it could take a little bit longer than that. But for most people, that's really the average time that they will be in the operating room. Bariatric surgery has become an extremely safe procedure, right? In a way, the fact that it has been treating morbid obesity, which is a condition that has been so highly stigmatized in our society, has made bariatric surgeons the target also not only of the society in general, but also of the medical establishment for many years as doctors who were really treating something that was not needed, right? As you recall, it's only been less than 10, 15 years since even the American Medical Association actually classified obesity as a disease. So we've gone for many years without really recognizing obesity as a disease. Therefore, bariatric surgery was seen in a fairly bad light for many years, and it had to really legitimize itself. Because of that, bariatric surgery has been under enormous scrutiny, right? And we had to really show that not only we had a great effective treatment at hand, but we had to make sure that it was safe as well. And because of that, bariatric surgery has undergone tremendous study, probably one of the best studied surgical procedures currently, right? And as a result, we have made huge improvements in safety to the extent that complex procedures like gastric bypass or sleeve gastrectomy now, Kemal, have the same safety profile as gallbladder surgery, hysterectomy. In fact, there are some papers that show even greater complication rate for gallbladder surgery compared to bariatric surgery. So that's where we are. So short-term complications of the different types of surgeries, and we obviously have the gastric bypass, the gastric sleeve, the most commonly done procedure, which are procedures that are intended to somehow modify the digestive tract. Infection can occur. Infection can occur in the short term because the stomach has not healed well, the intestine has not healed well, a leakage can happen, right? This can lead to a very serious infection. The good news, as I said, is again, this is an extremely rare event in programs like ours, where we've achieved such great levels of safety. But even if it occurs, obviously, we can take care of it, right? When does this type of infection tend to occur? Well, it tends to occur in the first 30 days, perhaps in the first 6 weeks after the surgery, right? And when we tell our patients about this complication, we also instruct them about calling us if they have certain symptoms, right? Whether it's abdominal pain, fever, vomiting, all these could be signs of a potential complication, and they need to alert us so we can take care of it in a timely fashion. Other things that can happen early after surgery include things like blood clots, right? Blood clots that can happen in the legs, that can travel into the lungs. This could be serious complications, come on. But again, we've made big strides in minimizing this complication. In fact, one of the increased risks for blood clots, Kamal, in any type of surgery are patients with a high weight. So our patients, by definition, have an increased risk for blood clots when they undergo surgery, because we've recognized that we've gone out of our way really to place prevention measures that have helped us greatly. In fact, as you know, all our patients just before surgery get a blood thinning medication, right? As we do our surgeries laparoscopically right now, the risk of bleeding has decreased greatly compared to the past when we used to do open surgery and we had the surgeon's big hands inside the abdomen manipulating structures, which had a high rate for bleeding, for instance, right? We don't do that. We use laparoscopy, which is very tiny instruments that manipulate the tissues very delicately. So the risks of major bleeding is very low. In fact, after laparoscopic surgery, one of the questions the anesthesiologist will ask the surgeon is, hey, what was the blood loss with this surgery? And normally is 2 cc, 2 mLs for such a big procedure, Kemal, right? So bleeding is minimal. And because we're so comfortable with our ability to control bleeding, then we can give blood thinning medication to protect against blood clots, right?
So if we were to go into long-term risk and complications, so if you can also summarize those, and then I may have some questions.
Absolutely, absolutely. So there are really two important ones to keep in mind, right? One is potential malnutrition, right? So lack of nutrients. This is much more common with gastric bypass and relatively less with the sleeve gastrectomy. And the reason is simple. When we do gastric bypass, we are rerouting the intestine to make it unable to absorb nutrients well. Well, because we want the patient to absorb less calories, but and side effect of that is that their ability to absorb very important, what we call micronutrients, like minerals, like vitamins, also decreases. So to make up for that, we want our patients to be on vitamins and micronutrients for the rest of their life. Not only that, we want them to commit to follow up with us in the long term as well, so we can do blood tests repeatedly, right? If those things are not in place, then the patient is in danger of becoming vitamin deficient or mineral deficient. And if these things are not taken care of, they can be very serious. The person could be at risk for hair loss. They could be at risk for weakening of their bones. They could be at risk for poor healing or being vulnerable to infections. They could be at risk for irreversible nerve damage. So these are serious issues. So once a patient commits to something like gastric bypass, they also have to commit to taking these additional supplements for the rest of their life. Not only that, they have to have a medical person supervise them so that they can do tests on an ongoing basis to make sure that these vitamins are in place. This happens a little bit less frequently with the sleeve gastrectomy because we don't reroute the intestine, but even the sleeve gastrectomy requires careful attention to vitamins and micronutrients.
For more conversations like this, be sure to subscribe. See you next time on United TV's Bariatric Friday. Stay united.